Okay, so this is my first case and curious to see what you guys think about it. This was a 40-year-old female who had this lesion. It's pretty T2 bright, but also has this area in it. We thought it was arising from the liver. And this
might not be of the liver though, huh?
Yeah,
because the liver is pretty plastic, and if you get masses that are adjacent to the liver, it can look for all the world like the things surrounded by liver. The claw sign tends not to be necessarily as reliable.
Yeah, definitely. And it's cystic, like this part was actually enhancing. I can show you the subtractions, but so we can see that it has a solid enhancing component and also a cystic component. So any thoughts?
I'm sorry, do you have the coronal by any chance?
Mm-hmm.
Well, one abdominal mass that can look solid and cystic and almost arise anywhere are endocrine neoplasms. So that's always going to be the differential for me.
Yep, good.
Just sometimes are also solid and cystic, although I can't really connect this to bowel.
Yeah, it didn't seem to be connected to the stomach. You can get extraintestinal GIST in the mesentery.
Yeah.
I haven't seen one up here like this. There's another lesion that you can get that's solid and cystic, and you can get it anywhere. So we were thinking like also about paragangliomas. They can have cystic change. We also thought about a nerve sheath tumor. And then also because it was like potentially from the liver, we brought up mucinous cystic neoplasm with malignant degeneration. And she would have been in a good age range for it, 40-year-old female. They tend to be from the left lobe, although they tend to be like more from segment 4. So anyway, this was resected and it turned out to be a neurofibroma with cytologic atypia. So I was just reading a little bit about it, but basically it's kind of like of the uncertain malignant potential spectrum. So you can have just plain neurofibromas, you can have the malignant peripheral nerve sheath tumor, and then in between them, you can have these neurofibromas with atypia, but it's a pathologic diagnosis. I don't think there's anything we could have said here. But the other nerve sheath tumor that you can get, or that can be cystic, is a cystic schwannoma. So I just wanted to pull this up to remind us about schwannoma versus neurofibroma. I vaguely remembered this from residency, but basically schwannomas are encapsulated and eccentric, and so they don't involve the nerve bundle or nerve fibers, so they can just peel the nerve open, scoop the schwannoma out, and then preserve the nerve, whereas neurofibromas are interspersed between the nerve fibers, so you have to resect the entire nerve. I think that is one reason that you could biopsy these ahead of time, or they can just kind of discover this intraoperatively and decide. But we have biopsied schwannomas and neurofibromas, and they can be painful if you biopsy them, but the patients that I've biopsied have done okay.
Your path was a resection or a biopsy?
It was a resection.
A resection.
Yeah, because they were concerned enough about this, and we went for resection. I think even if we had biopsied this and it came back neurofibroma, they still might have resected it because she was having symptoms they thought were related to it. But
it was presumably extrahepatic then, though, huh?
Yeah. Mm-hmm. Yeah. And then the other one we were talking about last week is the solitary fibrous tumor, which can arise from the capsule. So that's another thing to keep in mind.
Sometimes if I don't have an organ of origin and it looks like it could be, I usually think about this when it's more paraspinal. I'll just say neural tumor generically because they can sort of overlap their appearances.
Yeah. And then this is just a companion case where there was this kind of blobby mass on top of the pancreas. It wasn't causing any ductal obstruction. We really didn't know what it was. It was enhancing pretty homogeneously. We thought it could be a pathologic lymph node, a paraganglioma, but this was resected and this was a schwannoma. So I don't know what the take-home point is, but I guess they can be anywhere and they can be cystic. Okay, this is my next case. This patient, I'll just scroll through. So you can see that they've got some dilated bowel loops, some fecalization of the distal ileum, thickening of the distal ileum, and then it goes to the ileocecal valve here, and there's also thickening and kind of inflammation of the ascending colon. And there's a clue on this image here.
Can you scroll back and forth? Sorry.
Mm-hmm. So this is the clue area. And then this is the syndrome or thing I'm talking about is the fecalization of the distal ileum and thickening of the distal ileum and also of the colon.
I think Aarti gave enough clues. Cystic fibrosis, right? Pancreatic fatty replacement and meconium ileus, something like that. Those plugging of the bowel loops with mucus.
Yes, exactly. So the complete fatty replacement of the pancreas is the clue here.
Yeah.
And then this was distal ileal obstruction syndrome, or DIOS. It's basically the adult equivalent of meconium ileus, where because the patients with cystic fibrosis have abnormal fluid resorption, that's basically why they get mucus plugging up their lungs and their pancreas, which is why they get this fatty atrophy. And then they also get excess mucus within their bowel. And that causes basically a multiple bouts of obstruction and all this kind of like really thick stuff within the small bowel. So usually it causes obstruction at the ileal level. The risk factors for this are dehydration. Also, if they're not taking their pancreatic supplements. So these patients need to take pancreatic enzyme supplements. And if they're not taking enough of those, they can get this. And then also, this patient actually had a lung transplant. You can see that they've got the surgical changes in their sternum here. They had a lung transplant, so their cystic fibrosis was being treated. But this DIOS is more common post-lung transplant because some of the immunosuppressive therapies can also cause a lot of like GI issues. So I just thought it was a good example. And how
It's
you
like
treat
a
this.
classic film panel case. I think I got shown one of those ones.
Yeah, yeah, because it's nice. You can see all the findings on like and get the clue right there too. So, and then this is my third case. Let me just move this down. Oops. Okay. It's an ultrasound, so I have to be careful. Okay. So this patient was having pelvic pain, and I'll just go back first. This is the, sorry. So this was the uterus, looked pretty normal. There was a fibroid. And then just going, scoop, this was the right ovary. And then this was the region of the left adnexa, and this was the left ovary, we thought. So what do you guys think about this left ovary? It was measuring 11 centimeters.
Well, it's not normal. And then after
Definitely
that,
not.
clinical context needs to be invoked sometimes.
Yeah, so
An
we
MRI.
that would have been good. We basically said, you know, I mean, do you ever call just like a cystic neoplasm on ultrasound, or do you always recommend an MRI?
No, I mean, I think if you could call it, I think you could say, you know, suspected neoplasm. That they'll do markers if it doesn't seem to fit. You know, maybe they'll do a CT next and not necessarily an MRI.
Yeah. So we said this was concerning for a cystic neoplasm. And then I was talking to the OBGYN folks, and they said, okay, I said, are you going to do a CT or an MRI? And they said, we don't usually do any of that. We stage laparoscopically. So if we're concerned about this on an ultrasound, we'll just go straight to the OR. We stage laparoscopically. We don't need CT or MRI for staging. This patient,
I think that risks getting some false positives though on their laparoscopy.
yes,
Probably,
it
but
does. But actually they
yeah.
told me that was basically their algorithm. And so I don't know if it's I don't know exactly, but yeah, I even spoke to one of my med school friends who's OBGYN, and she said that that's what she does as well. So I don't know. But luckily, this patient came back before they were scheduled to go to the OR. And then luckily they came back with abdominal pain. And you can see they've got like polycystic liver disease and kidney disease. And this was our left adnexal mass. And that was the fibroid we saw earlier. So what do you guys think about the left adnexal mass now?
Can it be part of polycystic disease? I think it probably can.
Yeah. So actually this was a third kidney, polycystic kidney. You can see it now, right? Like it's a kidney.
Yeah.
And it just was it's a supernumerary third polycystic kidney. So I actually showed this at SABI
awesome.
a few years ago as one of those don't let this happen to you cases. Luckily that they did not go resect the polycystic kidney, and this was actually the ovary separate from it. So you can see that it looks exactly like the other kidneys, right? And then also it has a vessel coming off of like near the aortic bifurcation. So that is frequent if you have like a pelvic kidney. You often have like, you can trace the renal artery back to the bifurcation. So yeah, it was cute. And we saved the supernumerary kidney. And just as a companion case, this is another case I have of a patient with 3 kidneys. So here's 1, 2, and a third one here.
I've been showing supernumerary
Wow.
for years, but they never were my cases.
So a couple of points about supernumerary kidneys. So for example, this is the axial going through this case. It's frequently, I've read one paper saying it's more on the left and it's more on the right. So I have no idea. I don't think maybe it's either side. And it's basically when the kidney bud, which is formed in the pelvis, a fetal pelvis, it splits early before it busts through the mesonephric blastoma. So basically it just divides early and you get 2 kidneys. And then as they rise out of the pelvis, one will actually make it to the normal location. And usually the other one is caudal to it. The supernumerary kidney, so that means you can have up to 4 kidneys. That's the most that's been reported in the literature. And the supernumerary one is often malrotated. So it can have predisposed to having stones, infections, that kind of thing. But otherwise, it's sometimes just mistaken for a mass in the pelvis. And, if it's functioning, you just leave it in. If it's obstructed, you might have to remove it. And when I was presenting this at SABI, I remember I found out that cats are more prone to having supernumerary kidneys. So it's also a fun fact. Okay, that's it for me. Somebody was chatting in. Wow, great case, cool. Okay, anyone else? And Nelly, are you ready?
Yeah. I have one case. Oh my goodness, I have so much PHI on my screen, so I'm just minimizing everything. So like, no, it's okay, cool. So this is a case that came to us, no priors. And this was interesting because it was we had a disagreement amongst ourselves about what we think it could be.
Is it a medullary carcinoma?
Metastatic what?
Medullary carcinoma? Medullary?
Oh, medullary. Oh, okay, yeah. So, so this is not a eye test out. So we've got this infiltrative mass, and it's got sort of calcifications. It's there's probably vascular invasion. It's widely metastatic. There's adrenal mets and retroperitoneal mets. And so for us, we're like, is this, an RCC, as Kedar mentioned, maybe, medullary type. And I mean, or could it be urothelial? Cytology was like atypical urine cell. So
Nelly, would you also put lymphoma possibly? I mean, the renal one looks more like a solid mass, but the adrenals are almost like maintaining a little bit of their shape.
Yeah, I can see that. I see what you're saying. It's conforming to their kind of triangular shaped look. So this was the adrenal mass was biopsied and it came back as RCC. So I thought this was like, and just this is one. Of course, the most common like infiltrative mass is going to be RCC, even though we want to also put urothelial in the DDX. And in this case, it sort of crossed over in terms of that more of a, you get the bean and the ball, and it's looks more like a bean. So if it's a bean, you want to add urothelial in the differential diagnosis. But it's all, I mean, clear cell RCC is always the most common cause, irrespective, especially like renal pelvic tumor, like this one extends into the pelvis. So this is just an interesting presentation of a RCC. And it was a medullary subtype.
It was medullary.
It was not.
Oh, okay. I was like, wow, great, Kedar. I think this is a good example of like, I think this is a good one to biopsy if you're not sure. We actually, even here, we biopsy RCCs, large RCCs now as well.
Oh, really?
Even if we know they're RCC, yeah, because there are some, I think, like immunotherapies that can shrink them. And so, and then also like there's certain subtyping they're doing of them now. So even if we know like this is a large ball shaped mass, this is like RCC until proven otherwise, we'll still biopsy them. The very large ones, the ones that are like, going up into the IVC and stuff.
That's awesome. I'm sorry. I just looked at the histochemistry and it says it's not the conventional clear cell subtype. They weren't able to subtype it with the adrenal biopsy, but they said that this is not a clear cell like the conventional variant. So it could be medullary, Kedar. We don't have the subtype because I don't think we had sufficient data yet. More stuff is pending. Pathology studies, I mean.
Cool. Anyone else have cases?
So Aarti, I have one case. I don't have a follow-up, but can I show that one?
Yeah.
Maybe I can get some thoughts about what everyone thinks. Okay, so this is a young lady with Crohn's disease. This is her first scan from many years ago, and the problem is not in the bowel. The bowel has some findings, but just I wanted everybody to look at the liver. This is the first scan in which the liver was, so like in 2014, the liver looked like it was normal. And then here's the second scan, then she was lost and she came back. So 4 years later, one second. So can everybody see the liver?
Yes.
Right, so there were these lesions in the liver, multiple liver lesions. Adnexal. Okay. This is the axial. So that's the TI problem, and so does anyone have any thoughts about what these lesions could be? Then I'm going to show you a couple more scans. So since we were not sure, we asked them to, and it was a new finding, we asked them to repeat a scan with EOVIST. Okay, so here's, since we had a regular scan, so this is the scan with.
It's got this like halo appearance. It's like very subcapsular, multifocal, hemangiolioma.
Yeah, I mean, so the patient is completely asymptomatic for this, just FYI. So this is the 20-minute delayed scan, and most of them don't take up anything. And then there is one right here in the periphery that takes up EOVIST. So does anyone have any thoughts about what? And then this is the scan. This was the last scan, which was which was done and which kind of showed the same lesions, but some of them are smaller. And
how old is the patient, Kedar? You said it was a
she's a
female.
young patient. She's in the 40s.
Yeah,
So I
I was
guess-
thinking maybe they were inflammatory foci, like there's like little micro abscesses that aren't turning into big old abscesses.
So, but some of them have actually gone away. And see, this is the only one this is also an EOVIST scan.
Yeah, that one, I can't explain that one.
So anyway, we gave a differential, if anyone has any thoughts, but we were not sure. So we did some digging. And so initially we gave a differential of, some kind of adenomas or nodular regenerative hyperplasia. And then we did some digging, and here's an article that we found on patients who it's NRH associated with therapy for IBD. And there is a known association between basically between the thiopurine therapies. And so there are many kind of case reports that they don't know why it happens, but they know that nodular regenerative hyperplasia can happen in patients with IBD, particularly with treatment with thiopurine therapy. And this patient was actually on a thiopurine. So that's what we have given. We do, like I said, I don't have a histopath on that, but at least this is something that we should think about or know that it can happen in patients who are being treated for Crohn's disease.
That's really cool. I didn't know about that. I always think about NRH for like Budd-Chiari and congestive patients.
Yeah, so they can actually happen with, and I'm sorry, I really didn't get time to put a PowerPoint together, but NRH can happen with a multitude of conditions. And apparently this is one of them, treatment with thiopurines. So if you guys do, MREs and you come across these lesions, potentially that is one of the differentials that it can be. So that's my case.
Cool. Do you know if they're going to biopsy it or just kind of watch it for now?
We've asked them that it needs to be biopsied, but since she's completely asymptomatic, they're just not doing anything about it.
Yeah, that's reasonable. Okay, Victoria texted me that she has some cases. Are you there, Victoria?
I'm here, but somehow my PAX is not cooperating at all. I think I froze it. So.
We don't show too many prostates around here. This is quite a while ago. On the bottom, it's 4 or 5 years ago, and it was just a sort of a typical. Here's the ADC map with a lesion in the right peripheral zone. Here's the high B value, right peripheral zone, and then on the T2, that's the DWI, pretty hyperemic, and T2 is here. Thought I got rid of the annotations, but oh well. So the patient was treated. Now, I don't know if your centers are doing much brachytherapy, but we do some around here. So this is, and sometimes they get MRIs in the setting of the brachy. This one, they like to do, if they use this space OAR stuff, which is like this gel that they inject between the anterior rectal wall and the backside of the prostate. Sometimes they like to do an MRI just to get dosimetry right. But you can see the brachytherapy implants in there, and then there's this spacer stuff that's like a hydrogel. If you ever image this, in fact, we'll see that in a minute, later, this resorbs eventually. But during the episode, while they're doing either external beam or brachytherapy, it'll protect the anterior rectal wall from the radiation. So
yeah, Steve, I actually had this case on like one of these gel spacers on a known case panel, but I had one in clinical practice too that they had accidentally gone into the rectal wall with the gel.
I almost think like they might be interstitial with the gel here, because it kind of looks like, or maybe that's, looks like it might be submucosal, right? Like, cause that kind of looks like the muscularis here. And then it looks like the lumen is a little bit narrowed, maybe.
Yeah, I think they don't have a lot of space. And so
Yeah.
like I talked to some friends at UT Southwestern and they said that they've seen that before and the rectum does fine.
Yeah.
And it's because that gel is pretty inert. And like you said, it's going to resorb. So
Right.
it doesn't really cause like ischemia of the rectal wall or anything. So if you happen to see it in the rectal wall, like it's probably fine just because it's just like gel.
Yeah, I mean, you can describe what's going on there, but I don't think they do badly if it looks like it's kind of like non-target gel. And I think this wasn't done because of any diagnostic dilemma. I think this was just done for dosimetry more, even though it looks like it got protocoled with contrast for some reason. And we usually don't do it that way. You usually do a limited scan right after the seeds are placed for their dosimetry. So then that was about 2 years before the one on the top line, which is PSA failure, basically PSA rising. And so there's findings on here of like advancing disease despite the brachytherapy. One of them is nodal. So there's some nodal disease that has shown up in the interim in that sort of left internal iliac plexus here, where it wasn't before. There was a small node there before. And also, here's another node over here. And then also the right seminal vesicle now shows involvement and basically down to the base. And if you look at the diffusion weighted imaging, it's kind of positive in these places as well. So we don't do Axamin. I think we have Axamin, or we just got it recently, but or PSMA PET, but that's probably becoming more popular than doing an MRI for a PSA failure case. But sometimes, MRI will show you the findings of local treatment failure.
PSMA PET was just FDA approved.
Yes,
One.
I think we're going to get it. I mean, it's just hard to get it. When we only have like 2 million people in our entire state, compared to major metros that have like 5 million people in just the metro. So it's just a different economy of scale to accomplish some of these tracers that you're not using every day.
Totally.
I
I have a
question.
case that with a follow-up, if Victoria is still pulling up a case after your question.
Just a quick question about this brachytherapy. Do you know any of you if it doesn't work as well if you have like a higher Gleason, or like where does the decision get made about
I'm not an expert in the treatment selection. But I would say that yeah, if there's a risk for any extraglandular disease, if it's not lower grade in the stage, I think the effectiveness might not be as great as external beam or a prostatectomy for local control. But I don't have papers to prove that. That's just my sense.
Cool, thank you. Nelly, go ahead.
Okay, I'm going to share. Can you pause so that I don't accidentally? So, thank you. We had reviewed this case before, I think. And in this complex cystic lesion, adnexal lesion, one of the findings was this area where there's signal dropout on fat saturated image. This is the fat sat T1. And so you see these like little globules that are fat saturating. And so because of this, the concern was raised for a dermoid. And it was like a funny looking dermoid cystic lesion. So I have surgical path, and it confirms that this is just a dermoid, a really interesting looking one.
Cool. Did they say anything else about him, about the dermoid? Like it didn't have like malignant degeneration, it sounds like.
No, it didn't. They said it was a dermoid cystic lesion, mature cystic teratoma, like a dermoid cyst. And then it didn't discuss degeneration or malignant transformation.
I've probably seen a couple more complex ones like that over the years that, you know, you're a little bit scratching your head like, why does it look so lobulated and complex if it's just a dermoid? Because most of them don't look
Right.
so lobulated and complex appearing, but they can, I guess.
Yeah, I guess this is reassuring that like, if you see bulk fat, it's probably still a dermoid. It's like not like there are ovarian masses that probably have bulk fat. Okay, Victoria and Christine also says she has one. How are you doing, Victoria?
My PACS, I rebooted the computer, nothing's happening. I can show cases from my recent like fun lecture. I have like interesting cases. I can show from that if that, you know, but I'm unable to pull up PACS, unfortunately.
Okay, yeah, why don't you show a couple and then Christine will do one.
Well, why don't we, Christine shows and then I'll just fill up the rest of the time. Is that
Okay.
Good.
Christine, you're up.
Okay. So this is person that came to the ER with abdominal pain, and right away we see that there's this gastric outlet obstruction secondary to this kind of ill-defined mass, sort of centered in the area of the duodenum and also pancreatic head. It's quite large. It's about 6.8 centimeters. And then further down, there's this other mass in the mesentery, also quite large. So at this point, you know, we were kind of vague with our differential. So we said that, you know, this could be some sort of tumor, either of pancreas or duodenal origin. It could also, just given the fact that there's this other mass here, we thought that maybe it could be some sort of desmoid process. So anyways, I wanted to show the MRI, which I thought was interesting.
And Gitanjali is sending in a diagnosis for the paraduodenal thing as a hematoma.
Okay, yes. So that's also, yeah, that makes sense because it's sort of, you know, it's got these sharp edges to it. It's not really rounded.
Confined to the anterior perirenal space.
Yes.
And it seems to have like little globules of fat in it. So it seems like, and it doesn't really look like a liposarc. So I like hematoma too.
So here we go. Here's the T2. And on the T2, it looks like a very much T2 dark area that encases the duodenum. Definitely could be a could be a hematoma. However, it does enhance quite avidly. Actually, I think it might. Oh, here we go. So it's not,
avidly. Uh-oh.
Yeah, sorry, it's very
do a
emotional.
skin exam?
Let me see if I can. I'm sorry, what did you say?
Did anybody do a skin exam?
A skin exam. Why do you ask that?
Melanoma metastases is what I think.
Oh, okay. Yeah, so they actually biopsy this mass. Sorry, the scan didn't turn out very well, but this was all fibromatosis actually, which,
Fibromatosis, wow.
yeah, which like in retrospect kind of makes sense with the way it kind of looks on T2. It's you know, like super dark on the T2. And then in terms of the other mass here, you know, it definitely looks different from what we saw up here. And so this also enhances avidly. And
a solitary fibrous tumor?
Yeah, it kind of has that appearance for sure. So we actually just got the pathology back from this biopsy, and that was a neuroendocrine tumor.
Oh my goodness.
So, like totally two different process completely.
So much for Occam's razor on this one.
That's crazy. Do you see the primary neuroendocrine? Like, did you find any nodules in the bowel that's draining to that area? I can't really see. Because presumably this is the neuroendocrine nodal met.
Right. I'm not sure that we saw anything obvious. I think that the patient might be scheduled for a date scan, so I can, show the case again when we get that done.
Cool, very cool. As far as fibromatosis, I have seen them be both T2 dark and also T2 bright. Sometimes they have, I think, a lot of collagen. So I think just like solitary fibrous tumors, it can also be bright. So but yeah, this is a great case.
Typically when they're acute, they are brighter. And as they become more chronic, they get darker. Same for retroperitoneal fibrosis also.
Oh, that's good to know. So like maybe more edema in the
Yes.
beginning and then more fibrosis later.
Yes. And you can see, like, since we do soft tissue tumors a lot, we see different components. So some of them are acute and some of them are more chronic.
Cool. Okay, Victoria, you're up.
All right. So I'll show some. One second. All right. So let's see. Can you see it? Can you see it?
Yes.
Okay.
Yep.
So this is just, these are some cases that we've put together for like our challenging liars cases. So I'm going to show some of them. So this is just a lobulated observation at 28 millimeters. So what category would you assign it?
LRM.
Right, so LRM, right, we have rim arterial phase hyperenhancement, there's delay central enhancement, so this is slam dunk LRM, and this was, we go through all of that, this is LRM, and this was on path combined tumor, which is, a rare tumor, but sometimes they meet criteria for LRM. So another case I think I showed a few weeks or months ago. If you remember, this was an 8 millimeter thing that just had a tiny little enhancement and maybe a little bit of restricted diffusion. Really didn't look that terrible. And on explant, this one also ended up being a combined tumor. So this is, I guess, what I wanted to highlight is that this is our meta-analysis, right, with probabilities of, malignancy in the HCC in Liars 2018. And in LR4, which this observation would fall, notice that almost all, but not all, of the malignancies that fall into this category are HCCs, but a tiny minority actually are going to fall and be non-HCC malignancy. And this is the interesting part that we can highlight, that combined tumors can actually have appearance of LR4 or 5, and the proportion of the categorization varies from like 7% to 63%. But this was an interesting study in radiology in 2019 when they looked at a group of conventional HCCs, conventional cholangias, and then combined tumors, and they looked at their, at the survival curves, and you can see that, intrahepatic cholangia had the worst, HCC had, the highest, and combined tumors were somewhere in between. But when they separated the combined tumors based on the appearances, it was actually very interesting because those combined tumors which met the LR4 or 5 criteria really behaved over, in terms of the prognosis as if they were conventional HCCs, whereas LRM, combined tumors which had LRM really behaved like ICCA, and this was statistically significant difference. Another interesting thing is that when they looked at variables which were associated with survival, LRM versus LR4 and 5 was a predictor of survival, as was tumor size over 3 centimeters. But notice the pathology was not statistically significant. So this is one indicator that, pathology, the imaging appearance may reflect some sort of underlying biologic behavior better necessary than pathology. So that was fun.
Victoria, going back one slide to that where you showed the combined ones are doing even worse than the cholangios.
No. This was not statistically significant. So these two curves are pretty much identical.
Okay, so on this slide, the takeaway is not that the combined ones are like the absolute worst of them all. They're basically performing at just like as badly as a cholangio.
Right. So if you look at the combined as a group, they fall somewhere just as an entire group. They're better than like conventional cholangio and worse than conventional HCC. But when you separate the combined tumors based on their imaging appearance, you basically the combined tumors that are on imaging meet criteria for 4 or 5, their curve is not different from that of HCC. And then those combined tumors, which on imaging have LRM features, those the survival of those patients is similar to the survival of intrahepatic cholangio. That makes sense?
Yes, got it. Thank you.
Okay.
On the next slide, when you're looking at the multivariable analysis, so that's saying that the bigger tumors, they do worse, and then what the LRM tumors do worse too?
Right. So when you,
because they're like mets presumably or something.
no,
Sorry, go ahead.
Because there's something, so the imaging appearance is reflective of underlying biology, right? So it's known that HCCs which have LRM appearance tend to be more aggressive ones. And subtypes of HCCs which are associated with poor prognosis are generally are going to have LRM features. So what this table, this one study showed that when you look at all the liver lesions, combination of HCC, combined tumors, and cholangios, what was predictive of survival was tumor size and Lyer's category, but not the pathologic diagnosis. Does that make sense? So that LR4 and 5, regardless of if it's an HCC or combined tumors, do better than LRMs, regardless of what the pathology is. So if you have a lesion and it looks like LRM, it's 4 times as likely to have, mortality, right? Than everything else being equal if that tumor was LR4 or LR5. Does that make sense? And by the same token, larger tumors are also, everything else being equal, are at higher risk of mortality. Does that make sense?
Yes.
So, and again, notice like AFP level didn't matter, CA19-9 didn't matter, Child-Pugh didn't matter. So they only in this, and it's, granted this is only one study, but there's a similar study that looked at, it was similar design for CUS, and they showed the same thing, that CUS categories were predictors of survival and pathology was not. Oh, it was cool. Let's see what else. So this was a very.
This is a tangential question. If you have if you're worried about a mixed, like a combo tumor, is biopsy if sufficient to exclude that, or can you get sampling error where you?
No, because it's not like part of it is cholangio, part of it is by the WHO changed the definition, and so it's not like half of it is HCC and half of it is cholangio, so you can get, but it's like you have to have both elements in the same sample diagnosis. All right, so this is another cute case. It was 11 millimeter. It's a real case. You can see it has, non-rem aphy, no what, it had washout, but no capsule, hypotension hepatobiliary phase. So based on this was appropriately reported as LR5. and the patient was transplant candidate. So he was, going for his whatever every 3 months. So this was 4 months later. You can see that now the lesion is 28 millimeters, so really increased in size. Now it has rim arterial phase hyperenhancement, has delayed central enhancement. You can see it has targetoid appearance on hepatobiliary phase images. So if I just started with this image, with these images, you would have said, it's LRM. It was actually reported as LR5, despite the fact that the reporting radiologist recognized that this lesion has rim aphy and other targetoid features. So this patient was transplant candidate. So they send the patient, they prep the patient to get, TACE, and I think it was TACE that was supposed to get, and then as a bridge to transplant, and the patient came to tumor board, with this lesion, at which point I said, no, this is not LR5, this is LRM. So then patients had a biopsy, and this was indeed, he had resection and it was cholangium. So the teaching point here is that you don't, if the imaging features change, you don't stick to the prior category once imaging features change. So this was the kind of the growth pattern of this patient. It started out with this small 6 minute. This was the first time this lesion appeared. This is hepatobiliary phase images, and if you can see, this is how the growth is very interesting, right? So the lesion sort of slowly kind of was increasing over about 13, 14 months. And then all of a sudden in 3 months, it shut up, like it shut up from 11 millimeters to 26 millimeters. So the growth pattern is not straight line. So you can imagine that, so that's like a point to threshold growth that, between any two studies, you may, like at one point you may get threshold growth, at the other point you may not. And that's okay, because the tumors may not grow in a very linear fashion. And this is
Victoria, may I ask a question on that last point?
Yes.
So is it possible for an HCC to have a focus of internal necrosis? Like, could you have an HCC that has some necrosis in them?
Absolutely.
So when you're looking at that, how do you,
so,
like you mentioned that you shouldn't stick with the prior classification. So if the imaging features of the lesion changed, then you should apply the classification based on the current exam that you're looking at. So if you had a LR5 lesion previously, and then it kind of looks like now it has rim enhancement, then you would LRM that, even though it was previously categorized as LR5?
Correct. This is exactly what this case is illustrating. And
okay.
And if they resected this lesion and it turned out to be an aggressive HCC, that would have been okay.
This is very instructive. Thank you for showing it.
So it would have been okay, right? So categorization of HCC into LRM category is not an error. About 33% of LRM lesions are going to be path-proven HCCs. That's okay. However, keeping an ICCA in the LR5 category is an error, because we want to have as close to perfect positive predictive value of LR5 for HCC as possible. So anyway, so in this case, this is how the categories so started out with a 3. This was primarily on the first image, on the first study, was just hepatobiliary phase hypointense lesion. And it kind of stayed like this. It was a 3. And then by this study, it developed arterial phase hyperenhancement and washout appearance. So, and it was 10 millimeters. So we gave it a 5. Then it just was the first images I showed you is from this study. So it was a 5. And then again, by the time it got to the last study, the imaging features changed. So therefore, you don't stick with a 5, you change to LRM. And the reason being is, again, in every one of 3, 4, and 5, if you look at percent of HCC versus percent of vulvar malignancy, these numbers are not exact. So there's a tiny proportion in each of these categories, which is due to non-HCC malignancy. So typically it's a very small combined tumors, or occasionally tiny cholangiomas, as in this case, they can meet criteria for LR3, 4, and 5. But as they grow and become more typical, again, you have to reevaluate. And once you have LRM features, you go into LRM category. Anyway, so that's it, right? Or you want to show one more case?
Sure, do one more.
Okay. Oh, so this one,
Victoria, one quick point. I was just Googling about cholangio, like transplant, because that you said that one was resected. And I was thinking like, because it became an LRM, that's why they didn't continue along with transplant. And I just read, and I just found something that said Mayo and the Cleveland Clinic did a clinical trial where they did transplant for patients who had cholangios that were less than 2 centimeters. So they were calling them early cholangios. And those patients still did significantly worse than patients with HCC.
Right.
So they said even a small cholangio, like less than 2 centimeters, you should still be very careful to transplant them.
Right. And generally outside of, clinical trials, presence of cholangio is a deterrent from transplant. Anyway, so this is also a cute case, kind of a big round thing, 28 millimeters, didn't really have
except in the setting of PSC.
Right. We're talking about intrahepatic cholangiomas, right? In cirrhosis, yeah, or not in cirrhosis, in regular. Okay, so this was, 28 millimeters, has arterial phase hyperenhancement, no washout, no capsule, didn't have restricted diffusion, didn't have T2 signal, and notably was iso-intense to the parenchyma. Notice there's big kind of hypointense area centrally related to just fibrosis, but the area around the parenchyma was enhancing okay, and you can see that this lesion was completely iso-intense. So at this point, if we apply the imaging, our just major features, this would be LR4, but there is iso-intensity to the on hepatobiliary phase images, which is ancillary feature favoring benignity. So we can drop this to 3. So whoever reported actually reported as 4, but technically we can report it as 3. The patient went to 3 to 6 month follow-up route. So 3 months later, you can see that this lesion looks smaller. Still arterial phase hyperenhancement, no washout, nothing else. And now again, you can see that this area is completely iso-intense to the parenchyma on the hepatobiliary phase images. So now this is an interesting conundrum, right? Because again, the imaging features, everything stays the same, but now we have 2 ancillary features of benignity, size reduction, and hepatobiliary phase iso-intensity. But as you remember, you can't go more than 1. No matter how many ancillary features we have, we can only adjust the category by 1. So we can go by 2. So we can again go from 4 to a 3 and stick with a 3. But then size reduction is a fairly powerful predictor of benignity. So is there a way for us to get to a 2? Well, what you can do is you can go back and retrace the steps and say, this is something that is decreasing in size. So this is probably something benign. So you could, just based on the study, recategorize it as a LR2, not coming through here, but through the decision tree. So you can step back and reassess the lesion. The person who was reading this case was still unsure. So, he was trying to figure out 2 or 3. And the correct approach here, remember, if we have tie-breaking rules, if we, decide between 2 and a 3, you always have to choose the category which reflects less certainty. So in this case, LR3 is less certainty of benignity. So LR3 is the correct choice. Although if whoever was reading was more certain, they could have gone with LR2. But at this point, they still stuck with LR3. And then patient came back now another 3 months later, and you can see now this thing is even smaller and everything else stays the same. So now we can safely say this is just a vascular shunt, and then patient just went back to routine surveillance. I want to point out, like, this is side by side arterial phase on the three imaging studies, and notice how the timing of the arterial phase is different between the 3 images. So this just highlights that the shunts, right, the size of the shunt can vary depending on the timing, and the size, you know, when we talk about growth and size increase, growth is only applicable to actual masses. So the vascular lesions can change in size, increase or decrease, but that's not really growth. That's just change in size depending on the timing of the phase. And you can imagine that I mean, here was easy, right? Because the lesion was clearly decreasing in size, so it was easy to have, to say this is just a shunt. But imagine if this was the index study and this was steadily looking like it's increasing in size, it probably would have been a little more challenging to be confident and say, this is just a shunt. There's just another cool case. So
that was awesome, Victoria.
That was
Thank you.
awesome.
That was super helpful. I feel like it's like this complex board game with like all these rules, and like it helps to like have you re-emphasize these rules, since I didn't read the LIRADS manual that you beautifully wrote. So thank you.
I have to admit, I'm not good about looking for those benign features real hard and down, like going from a 4 to a 3.
We often don't, right? A lot of times we, I feel like application of answer features in malignancy is much more common thing.
Yeah.
If you routinely use EVIST, I think hepatobiliary phase is really, really helpful in terms of dismissing these things as shunts and not even assigning category to them. But when there's something decreasing in size, it's easier to say it's benign.
Definitely.
I know we're past the hour. I have a case that's relevant to Victoria's lecture. Should I just show it next time?
Yeah, I actually have to hop off because I'm late.
Yeah.
Yeah, next time.
Cool.
Okay.
All right.
Bye, guys.
Bye.
Guys.
Great. Thanks.